Good evening, everyone, and welcome to tonight's webinar. We're excited to have you with us this evening. We'll be allowing a 5-minute window to enable more registrants to join. Due to our strict privacy policies, we kindly ask that any AI note takers be disabled for this session. If we can't tell that they've been turned off by 6:05 p.m. EST, we will have to remove you from the session. While you wait, please participate in the poll that should be popping up on your screen shortly. Your responses will help us better direct the information for tonight's session. Thank you for your cooperation and enjoy.
Hi there and welcome. We're so excited to have you. It is going to be a great night. And welcome to the DNA Company and the Pharmacogenetics.
We are diving into a transformative topic tonight that holds, I would say, the power to revolutionize medicine in your healthcare. What do you think, Steph?
Absolutely. Your healthcare, totally, because this is going to really walk you through what can I take? What should I maybe not take? How can I risk having, or avoiding those pesky side effects? I mean, that's what really we're going to look at is how do you optimize your health in the event that you actually need a pharmaceutical agent? When I was growing up and I was a kid who was bound to be into drugs. When I was 2 years old, I had a drug salesman behind our house, and he carelessly let a bunch of pills out. Well, they were all so pretty. They were yellow and red and blue. And so I took them and they had to take me to the ER and have my stomach pumped because I don't even know what I had. And then when I was 4 and my brother was 2, I fed us a whole bottle of baby aspirin, old St. Joseph's baby aspirins, and I had to get my stomach pumped. And, so I went into pharmaceuticals. My mom said I should have known she was a druggie from day one.
That's funny. My own little anecdote, and it's so funny, where life takes you. Here's how maybe in the same context I was always meant to get into supplements and ingredients. I must have been barely old enough to climb up onto the kitchen counter. And then on top of, this is a home from the 70s, I'm recalling, where the hood fan sits, separate to any cupboards and with some weird, funky. I climbed up on top of that where my mother kept her iron pills, and I ingested a whole bottle of iron supplements. They had to do the same, bring me to the hospital, and to the point where I think they were suggesting they were seeing kind of streaks and speckledness of brown deposits in my eyes. So I had iron toxicity, there's no question, but they got to me in time, because even too much of a good thing is not a good thing.
Right.
And to your point earlier, I think this goes beyond the innuendo of, small problems. This could be hugely problematic, couldn't it?
Sure.
Pharmacogenomics is this whole incredible new space where even if you have subtle side effects, combining 1 or 2 or 3 different drugs, that's one thing. But if your genes don't like what you're taking, that's a whole other thing.
Which happens more and more often. And I think one of the things we should talk about is let's lay some definitions, because I think it really will help for us to say, what is genomics? What is pharmacogenomics? What is nutrigenomics? And why don't we have you start with some of those?
Yeah, well, why don't I do genomics, nutrigenomics, epigenetics, that kind of thing, and then over to you for the pharmacogenomics, Doc, because this is your area of expertise. And of course, we talk about this all the time. We preach it. Genomics, the idea and the slogan we like to use is that you can't change your DNA, but you can manage genetic expression. So genomics is the study of DNA, your genetic blueprint. We like to think of this as your instruction manual. It's what makes you you. And these instructions, they can encode for hair color, as we know, height, and all kinds of different phenotypic presentations, but a whole lot more, including diseases, predispositions, how you detoxify, how your hormones work, what letter vitamins you may need more or less of. But genes only tell part of the story. Epigenetics, nutrigenomics, this is the study separately and together of your environment, lifestyle, the choices you make, and how all of that stuff influences your genes and how they express. So kind of like dimmer switches on a light, right? You might have certain genetic predispositions, but how you brighten the genes, or in some cases just turn them off altogether, or on, depends on what you eat and how you sleep and your stress levels and so on. When it comes to nutrigenomics, of course, using dietary interventions at therapeutic ranges, or in some cases ingredients or supplements, to up or down regulate, dim, or turn on, or in some cases off, if possible, some of those genes and how they express. But then enter pharmacogenomics. Let's zoom in on that.
Right. So all of our pharmaceuticals were either derived or got their beginnings with plants. Okay. And our body processes plants, and then they run down various pathways, whether you look at a phytoestrogen, okay, and then that could augment our hormones. But then we have synthetic estrogens. We have mimetics, meaning they mime or they copy. We take maybe animal hormones, i.e. Premarin, the 7 different hormones from a horse urine, and then our body processes those. So pharmacogenetics is how do pharmaceuticals that have been refined, stabilized, controlled in the amounts they're doing, how do they go through your genetics? And it's important for you to know, sometimes we can metabolize them, sometimes we can't. There are chemicals that are forever chemicals, i.e. metformin. Many of you may be on metformin or know someone who's on metformin. That chemical when you take it as a pharmaceutical, does not break down, does not go away. So when somebody says, oh, I changed from my 500 to 1,000, I'll just dump those into the toilet. They go into the waste sewage and then out to be processed. But that metformin stays, whether it comes back into your drinking water, whether it gets pumped out to a lake, and then all of a sudden the fish are all on metformin. So what we want to talk about today is, and you saw this maybe in the questions, have you ever had a side effect? Well, I'm going to tell you right now, there is no such thing as a side effect. Are you ready for this? It is a direct effect. Side effect is a very nice word, like pre-diabetic. Okay. You have diabetes because you have a blood sugar dysregulation, but nobody wants to tell you you have diabetes. So it's like, well, you're just right in the range. You're pre-diabetic. You're actually a beginning diabetic, but you have a chance to reverse it. A side effect is a direct effect, but it's not the direct effect that your medicine was prescribed for or marketed for. It is a marketing term. So every time you take something and then go, ooh, didn't make me feel good, that's not necessarily an allergy. A lot of people like to call it. And I had an allergic reaction. I had an upset stomach. That's not an allergic reaction. This did not create histamine. You didn't go into anaphylaxis. Okay. You had a negative effect because your body couldn't process it for one reason or another. So what if you didn't have to go through all that trial and error? How many of you have been through 1, 2, 3, 4 drugs in a class or category, and none of them seemed to work right? And your doc was scratching their head and going, well, we'll try another one. Well, we'll try another one. What if you didn't have to guess? What if you could get and shorten that path right from the beginning? Or what if you failed and failed and failed and you finally just decided, well, it's just good enough. This is all the better it's going to get. What if you didn't have to do that? What if you could get a little bit of insight using your genetics as to the pathways that you might be able to manage better without those direct effects that we call side effects, or without lacking therapeutics? Like, this is supposed to do X, which helps my health become Y, but I'm not seeing any difference. I still have headaches. I still have blood pressure. I still have, what if we could show you a way, almost like lifting the curtain, to see based on your genetics what might work better for you? And I'll give you an example. My father was put on a medicine, and he's given me permission to say this, but he's had OCD and anxiety. Well, he was a very high functioning executive, and he had a company that had 200 employees, and he was never worried about putting out a good product. They put out a good product. He was worried about taking care of those 200 families, because 4 people a family, that's 800 people that were responsible for him producing. So he had this ongoing anxiety. Well, he had a practitioner that said to him, you're just depressed, and put him on Zoloft. Now, Zoloft is not a bad drug, but there's a rare reaction. Less than 2% of the population. And guess what? He had that reaction, and he developed what was called hyponatremia, where his kidneys bottomed out. He kind of got disoriented, and everybody said, is he drunk? Does he have dementia? Is he, and the ER physician, when we took him in, just brushed it off. He's just a dawdling old man. Well, having a daughter who's a bit assertive, wink, wink, nod, nod, said, let's run some labs. His sodium was so low that if it had dropped 2 more points, he would have gone into a coma and we would have lost him. It was a direct effect from his Zoloft that was a side effect that was listed in the package insert, and no one knew genetically he couldn't handle it. When we did his PGX to get alternatives, because he wasn't depressed, he was anxious. He needed his GABA to go up. We could see that in his DNA. And then we could also see in his PGX that Zoloft was the worst choice for him. Why did his prescriber prescribe it? Because that was the one they were the most familiar with. That was the one that they commonly produced. how fabulous would it have been, especially because my father was a senior, that we had done the PGX first before trying a drug on him and avoiding. He spent 6 weeks in the hospital, 6 weeks recovering from that drama. And the next 14, 17 years getting his kidneys to work again. So they finally work. But now, of course, with his anxiety, he's always afraid they're going to fail again. So every time a drug comes, we pull out our PGX and we look, and what can we do? What could we manage? And what other alternatives do we have? So I personally have a passion tonight about making sure you don't have to go through what our family went through, that you don't have to go through what my father went through, that you don't have to go through what anyone who has ever had a devastating side effect goes through. And we're very proud to be able to produce a test that gives you that little bit of edge to maybe not having that kind of a disaster in your family. Bryce?
You know, hindsight's always 2020, but like anything in life, having a guide, a manual to fall back to before you make decisions, you can get rid of a lot of that hindsight. SSRI, selective serotonin reuptake inhibitors. There's a high percentage of the population that have intolerance from a genetic perspective, pharmacogenetic perspective with this classification of medication. And they're great, but just sometimes the, specific one for you, an antidepressant, is good to know. Of course, as you're describing, sorry to hear about that with your dad. Besides the fact they can increase serotonin levels, they can also stimulate the release of antidiuretic hormone, right? And that causes the kidneys to retain water and then diluting sodium levels in the blood, and then it can be problematic. But
hyponatremia.
Say that again?
The hyponatremia.
Yeah, that's it. Well, that's the backstory of it, right? I just, correct me if I'm wrong, wanted to sort of recapitulate or summarize everything that you said. And it's important folks understand pharmacogenetics is where the genetic story meets the medications you take, just as Dr. Steph was describing, and the science of understanding a very unique genetic makeup will determine how your body processes, absorbs, and then, of course, responds to drugs in that very direct manner. No side effect, direct effect. And here's the shocking truth. Up to 90% of us carry genetic variations that impact how our medications work. Some people process a drug too quickly so that it doesn't have time to work. Others actually metabolize it too slowly, leading to side effects, toxicity, or direct effects. So in short, obviously what works for one person doesn't work for another. One man's meat's another man's poison. So yet for decades, as you were describing quite eloquently, medicine at large has been using this sort of trial and error approach. So this is an important conversation that we have today. What are some of the most important, other than SSRIs, as we've identified, common drug, implementations that carry these side effects that are seemingly genomic? I mean, I know opioids are one of them, and we have an epidemic that way. SSRIs. What are some of the others?
Well, a lot of cardiac drugs don't get metabolized in, always effective pathways. Drugs that need any of, as I call the Asian nation, sulfation, glucuronidation, methylation. So drugs that have to be converted in order to be utilized or eliminated. If they're not, build up with toxicities. And so we can look at that. I think one of the biggest things that I see in practice is that a lot of people, and I think almost anybody tonight could relate to this, they either know if they're super sensitive or they know if they're not super sensitive. I have patients all the time that say, I take half of whatever is recommended, whether it's an over-the-counter or something, because I always have side effects. Or someone has said, it doesn't matter how much I take because it's never enough. So just like somebody says, I can take a cup of coffee at 11 o'clock at night and go right to bed and it doesn't bother me. Though, yeah, okay. Or someone like me who does not have good detox pathways, I can have one at 1 o'clock in the afternoon, and at 11 o'clock at night, I still am flying, because it keeps around. So, there's a lot of that type of thing. that is
sure.
going around when you can't detoxify.
Well, and the average American is currently taking 3 to 4 prescription medications at any given time. You would correct me if I'm wrong on that stat. About 20 or so, 25% of Americans take 5 or more medications. And the risk of crossover, I think it's after what, 2, 3 drugs, something like that. After 3 for sure is 100%, right? Polypharmacy. And what is it like? Something astronomical in terms of what that does to contribute to hospitalizations, let alone chronic disease and organ dysfunction over time if it's not suited well to your genetics. Something like 40 or 50% of hospitalizations in older adults is attributable to side effects and
Iatrogenic.
mistakes made by doctors on prescription
Right.
drugs. Right.
Yeah. Well, and depending on who you talk to, the third or fourth leading cause of death annually is iatrogenic medicine, meaning
Right.
doctor-induced medicine that even within normal limits, okay, you're supposed to take 250 3 times a day, or you're supposed to take 500 twice a day, end up with effects that can really devastate people, throw them into the hospital or kill them. And it's just horrible to know that people are trying to do good. They're trying to help. Nobody's out there writing a prescription because they're trying to hurt you, but they don't know your DNA, because DNA is not a common part of practice yet.
Right.
And in fact, even when a lot of our patients will take their DNA reports to their prescribers or to their primary physicians, they're like, yeah, right, I don't know what to do with this, because it's just not part of their training. And unless you're a geneticist, it's usually looking for statistical analysis. They're not looking at that. Now, I can tell you, when you print out a pharmacogenomic report and it says, this is the most ideal for this patient, this is the second best, this would be the least effective, this you should never use. They look at that. I mean, it's a little bit like a stoplight, green, orange,
Pretty easy
red.
to interpret.
It is pretty easy to interpret.
And I don't know if this will pan out or not, but I do know that Tracy, our CEO, is standing by, as she often does, to add color to some of our conversations. Sometimes we have people asking questions we can't answer, like what's the latest sort of deal and package, because we have so many tests that we offer now at the DNA company, thanks to her ingenuity. But part and parcel to her, Tracy, forgive me if I'm putting you on the spot, but I really believe that this is a story you don't mind sharing. Part and parcel to her core impetus, the ethos, and what drives her, to day in and day out be our leader and CEO, is a very personal story that, should there have been this type of testing available to her and her family at a very, very sensitive time, it may have changed everything. Tracy, I don't know if you're there or able to chime in with us. And if you are, maybe if not now, maybe we can pull her in sort of toward the end. But there's a story that's very near and dear to her heart that she's told publicly, which is why I know she's fine with it. But should there have been a PGX test available, may have actually saved the life of a family member, that was close to her. So I don't think she's available right now, but
I'm here, Doc. I'm playing my Xbox because I'm home from work early today.
So what I was saying, I don't know if you heard me. I didn't mean to interrupt.
Yeah, I heard you. So yeah, that's true, Bryce. So a lot of people don't know this. Some people that are close to me, like you and Steph and a few others, do. Yeah, my eldest sister died. It'll be 18 years, February 3rd, this coming February. And she died of a drug overdose. And the fact is, my sister was schizophrenic. Most of us did not know. And she was being treated by a doctor that literally had 7 minutes to spend with her to adjust medication and treat her and treat her. And that happened for 5 years. He was actually at UCI in Irvine, which is a very prestigious medical facility, as well as a medical school. And 7 minutes every month for 5 years. And he gave her a combination of drugs that, had we have had her pharmaco report. And it's important to know that back then, pharmaco had become a thing, but it hadn't become widely accepted. It was being tested in tertiary centers only. And it didn't become a thing until about 2016, before it was widely accepted and used as standard of care. So Jackie went to see her psychiatrist. He gave her her new and improved schizophrenia med on the 28th of January. And her lungs shut down the night of February 3rd. So pharmaco affects more people than any of us recognize in the United States. You know, in fact, it's every one person in an ER right now has had a medical mistake made since they got there. Every single person. That's a statistic that's horrific. 1.3 million people are injured by what they call avoidable medical mistakes, meaning somebody didn't check a pharmaco, somebody didn't check a lab, somebody didn't check a contraindication. Every single year in this country, 7,000 people die like my sister did. That's a lot of people.
Mhm.
And if you look at, we are empowered in America, right? We are empowered in our health. We can go out, we can go buy a pharmaco report. We can go and buy our DNA 360. We can figure out how we function in the world. And there's so many people that won't do that because they look at their health as an expense rather than an investment. Any of you that are over 40 on this call, you're on the last half.
Mhm.
This is your last half. And you should recognize that your last half has got to be better than your first half.
Mhm.
And in order to do that, you need to know how you work. You need to know what your body will react to. And Steph is, Dr. Nielsen, I'm sorry, honey. Dr. Nielsen is right when she says that side effects are direct effects. Your body did not want that medication for whatever the case may be. Your body didn't want it. It doesn't work for you. So, you know, don't necessarily buy everything that's written on the side of a package. Side effect was a great marketing tool.
Mhm.
And pharmaco would have saved my sister's life, Bryce. You're right.
Mhm.
Thanks so much for sharing that very intimate story about Jackie, and God rest her soul. And the sad reality, as you were also describing, is that we probably, distant family, cousin, we know somebody that unfortunately had the same demise, and it can be this doesn't have to happen. With a
Right.
simple test. There, part of the messaging this evening, Dr. Steph, is that we are all about the use of sensible, well evidence-based drugs that suit the individual if and when necessary, right? With good and effective comprehensive due diligence, which this is a huge part of.
Well, and I was going to say, as a pharmacist for 40 years, I'm going to take that a step further. Pharmaceuticals should be reserved for when your lifestyle changes, your food changes, your supplement changes have failed you. If you are so far gone that, for example, you have a leg cramp and somebody reaches for Advil for the leg cramp rather than some magnesium, okay. So if you have a cramp, calcium constricts, magnesium relaxes. Whether you have menstrual cramps, whether you have leg cramps, Charlie horses, we've got a chemical imbalance, a mineral imbalance. Try some magnesium first. There's multiple forms of magnesium. Some just help you poop. That's not the one you would want. Some help your heart, some help your brain, some help you sleep, but try some magnesium. And if that cramp goes away, your body was saying, hey, I need some more magnesium. They weren't saying, I have an Advil deficiency. Okay. So what that Advil is going to do, yes, it will make your cramp go away or feel better, but it's shutting down the body's natural way to say, this is not working for me. So I have no problem with people having pharmaceuticals. The sadness I have after so many years is people give up on their diet. They give up on their lifestyle changes. They give up on, well, I tried this over-the-counter supplement that I got from XYZ, generic store. And maybe they didn't get a high enough quality. like a lot of the fish oil capsules are actually full of seed oils. I mean, you're getting canola oil, not necessarily a seed oil. A lot of them contaminated, a lot of them are rancid. Oh, it didn't change my cholesterol. Oh, it didn't make my brain better. Well, are you using a high quality one? Because high quality ones are going to cost more. Are you using a therapeutic grade one? Are you using a therapeutic grade? So I believe, and this is just my own personal take after so many years of my own health challenges, of my family's health challenges, and have being in practice, is I like to reserve pharmaceuticals for when what you've done yourself doesn't work. Now, I had a gal who did not want to be on any medicines, and she had a failing thyroid. I'll tell you what, you can't eat your way out of a failing thyroid. And I finally said, really, you've got to go on this unless you want to weigh this enormous amount and be sluggish and lose all your hair. Turned her right around. Well, she'd go on and off of it over the next few years, but I really don't want to be on it, but I want to be on it, but I really don't want. And I'm like, look, at this point, your body is saying, this is a life-saving drug. We need to stay on it. No more flirting with it. And she did, and she's doing great. And as much as she doesn't love being on it, that one actually has been extremely therapeutic, extremely helpful, and she's had little to no side effects. When does she have side effects? When she's not on it, because then her thyroid goes back into failure, and roller coasting her thyroid is not a good way to live, you know?
Sure.
So,
yeah. Well,
you know,
and you mentioned, I'm going to use this as an example because I often hear this cutesy little sort of term being thrown around irresponsibly, I think, in the world of functional or natural medicine, if you will. And, you can't be deficient in a drug. When you had that, use that cramping, example scenario, you can be deficient in magnesium, but unlikely, or in fact, impossible to be deficient in Lyrica, right? You're not going to be deficient in that drug, but you can definitely be deficient in a hormone. And some drugs are hormones. And in the case of Synthroid, some people, for whatever reason, may need to take a drug. And in fact, in this instance, it's a perfect example of being deficient in otherwise what we would describe as a synthetic hormone, but nonetheless, something that somebody needs to function properly. Their thyroid's not working. What we like to do at the DNA company is understand why their thyroid's not working, get to the root cause, and identify any immunological imbalances and really do the deep dive. We have wonderful clinicians who can do this for you. But if you have to take a drug, and it does have inference around pharmacogenomics, that is to say, what genes dictate you're better with this versus that. And that's what we've been talking about. What is pharmacogenomics? The fact that there is no one-size medications. Maybe before, though, we get into the unique DNA that influences certain medication responses, maybe what we should do is pull up the poll, get a sense of what everyone
great idea.
is.
Sure.
Yeah. Over to you.
There we go. So how often do you experience side effects? As we know, okay, direct effects from your medication that you've been prescribed. Rarely, 27%. Occasionally, 48%. That sounds about right. Frequently, 12%. I'm in there with you. Or 13, almost always. So look at that. We've got about 50% that said hit or miss. Yes, sometimes no. And I would bet the reason that that's the case is because they're getting different types of medicines that go down different pathways and different metabolisms. So some hit and some don't. Knowing their genomics would help to say, hey, this pathway is not going to work therefore. And if you look at the 27% of rarely, or if you look at the other 25 between frequently or almost always, those would be the people who end up having the poor metabolic detox pathways like me, that things build up, build up, build up. I have to take half of as much as they say, or if they say take it every day, maybe take it every third day, because I just don't get rid of that. And then it builds up in the system with that half-life of that drug. So, all right, let's look at question 2. Have you ever had to switch because the first prescription you had didn't work effectively? Yes, multiple times. 30%, 29%. That's amazing. Yes, once or twice, 42%. No, my medications usually work, 20%. And I'm not sure. Maybe they switch for some other reason. But yeah.
And what's interesting, the difference between these two cohorts, these two different groups, the first one, as you're describing, is a reflection as to perhaps challenges, suboptimal variations, we call them,
Mhm.
within detox pathways. Whereas number two is really more framing up those individuals who probably have to switch medications because they didn't work effectively the first round, because they hypermetabolize them. They may be actually overly excessive in their ability to break down. That's oversimplifying things. Of course, there are other reasons why, poor choice or selection of the prescription in the first place. Of course, even others than that. But it's an interesting dichotomy that we see. You can be a hyper detoxifier, very, very efficient in your ability to break down. Then, of course, I mean, you described this better than I would. A drug isn't ever in its, or rarely, I'll take it back, but most of the time isn't in its active form.
Mhm.
Most of the time, it's in a form that needs to be broken down, most often by the liver, into an active and a metabolite, something that you got to, sort of get rid of. But the active then is what your body needs to use to have the medicinal, therapeutic, or drug outcome, right?
Or to
So
have
the
a
speed,
sustained outcome.
right,
Exactly.
and the speed at which you process or metabolize that, because of course detoxification, in essence, to overly simplify that process as well, is to take something from its active form, and once it's done its job, turn it into something water soluble so that we can pee it out, poop it out, breathe it out, sweat it out, get it out of our body.
Mhm.
Kidneys, liver, in particular.
Mhm. And we'll go to our third question real quickly. How familiar are you with the concept of pharmacogenomics, using genetics to tailor your medicines? I'm actually a little surprised, but 6% of our population is very familiar. They've actually explored it, they've looked at it, or they've spent some time. Somewhat familiar, kind of know the basics, 19%. So again, we're looking at about 25%. We have a very educated population. I love
Yeah.
working with our clients because they are so interested in health. They are so interested in their health and the health of their family and loved ones that they'd love to share. C, I've heard about it, but I don't know much, about 50%. And then this is my first time ever hearing about it. Well, welcome. We're glad you're here. We hope already you understand that every time you put a substance in your body, whether it is a chemical from a lotion, whether it's a fragrance, whether it's a food, or whether it's a pharmaceutical, all of those are processed through your body, and they can all, some people say, I'm so sensitive to fragrances, I can't be around any fragrance. Or Bryce, as you were talking about, you're having cats, and then when you change your filters, what a difference it is in your house at the end of a year, and seeing how those filters just look filthy. You're like, we have such a clean house, how could these HEPA filters be so contaminated?
Well, I have this saying. And just quick backstory is, we were talking off camera, Dr. Steph and I was mentioning how 4 years ago I had a major back surgery, which, by the way, incidentally, I am a very fast detoxifier. And incidentally, when I was anesthetized, and my anesthesiologist, very wonderful, warm, seasoned veteran of a anesthesiologist, Italian guy, he gave me these analogies of wine coming into my body as he told me to count back. I gave you the Chianti to start, and now comes the Barolo, and I'm counting backwards, and I'm at like 72. I'm not out. And he's like, this is strange. He had to try like 3 or 4 cocktails on me before I would go out. So anyways, I'm a hyper metabolizer. That story aside, when I'd had my surgery, came out and in recovery, I have cats. I developed a weird allergy to my cats, like all of a sudden. So traumas, surgeries, motor vehicle accidents, they can cause your body and your immune system to do some pretty funky things. So I changed all the filters and got HEPA filters everywhere in my house, obviously. But my point in saying all this is, if you don't have filters, air, water, RO or otherwise, then you are the filter.
Right.
But the whole point here is that let's take it one step before that. You know what your filtration system is by looking at pharmacogenomics. You know what your potential, your capabilities of filtering, detoxifying is with this report. Pharmacogenomics is the art and science of studying your ability to take certain exogenous or toxins from the outside. Sometimes you need to put these things in to have a therapeutic effect. I don't want to call all drugs toxins. That's not what I'm saying, but they do have potential toxicological effects when they're not matched. So if you don't want if you don't have this sort of filter, if you will, of a pharmacogenomic report letting you and your doctor know what is best for you, then you become the filter, and that filtration system can quickly become burdened, overworked, and or sluggish, and then there are bad side effects. We talked about adverse drug reactions being the fourth leading cause of death. Dr. Steph mentioned that.
And actually, I saw Trudy put in that she'd looked it up. It's actually now the third leading cause.
Third leading cause of death. And this is costing the healthcare system
Tons.
like over $140 billion annually, right? So, and genetic variations contribute to anywhere between 20 and 40% of those severe adverse drug reactions. So let's get into the nitty gritty. Like, for example, there's a lot of these are CYP genes. We study some of them in the DNA 360, cytochrome P450, like the 2D6. Can build up toxic amounts of opioids. Just today, there was a I can't remember where, I think it was New York City. There was a police officer who had come into contact, I think, with a drug, a street drug, an opioid, and had to get emergency treatment. Would have lost his life. It was in the front page of a local New York paper. But you can Google this; it's probably still headlines. And then there's other CYP systems that make antidepressants, we sort of alluded to earlier, ineffective or cause side effects. What are these genes? What is it, a this for that scenario? Do some genes, detoxify a multitude of different drugs, different class? Like, walk us through, what are we looking at on a PGX, Doc?
Well, the PGX actually doesn't go into that. And I don't actually know that it's probably important for us to go through that. I think what's important for people to know is if your family has, say, consistent cardiac side effects or cardiac issues, we know on our DNA 360, we have a whole cardiovascular section. Do you have cardiovascular inflammation? Do you have problems with your lipid imbalances? How do you respond to statins or not respond to statins? And again, Denise was saying that she got multiple muscle tears from using a drug that was a statin because she is a very slow producer or eliminator of statins. I can tell you, I have actually had, it's called rhabdolysis, where the muscles will pop. And when I dispense a statin, I will say, there is a rare side effect. If you're walking along, and all of a sudden you feel like your leg is snapping or you get a catch, I need you to stop. Just hold still, freeze, breathe, because what can happen is those muscles can tear and you can, snap and lose that muscle. Now, again, while it's very rare, I'd rather you be aware of it than not aware of it and try to push through it. This is not something to push through. So if your family has some of these, like, oh, everybody dies. I had a patient the other day. Everybody in my family dies of heart attacks. Everybody's died by the time they're 40. He's in his mid 50s. He goes, I know every day is a blessing because every day is a gift because nobody's lived as long as I've lived. This is somebody who needs a PGX because he's on, what I see, and I'm sure there's a statistic, but for every decade of life, someone's on 1 to 2 meds. So by 40, a lot of my 40-year-olds are on 4 to 5 meds. By the time they're 60, they're on 6 to 12 meds. I mean, unfortunately, I have some 38-year-olds that are on 25 medicines. And it's like, how can you not have these interacting to each other and clogging the systems to detoxify? But they're afraid to go off, or they've got so many different physicians, specialties here and there, that you end up not wanting to make a lot of changes. And so a lot of what I do as a clinical pharmacist is do medication therapy reviews where I will go through and say, this may be overlapping. This may be overlapping. Do you know how easy, if I had this report in front of me, it would be for me to go, this patient, based on their DNA, really needs to not be on carvedilol. Propranolols can be a much better option for them, or we might want to consider that due to their, and then list that. I think
Right.
so many physicians would just say, abso-flippin-lutely, this would be great. Because when they have fewer side effects with their patients say, oh my gosh, this physician is fabulous. You got to go to them. They know so much. They're so happy. They make me feel so great. They took care of my problem. They really listened to me. Well, what a great cheat sheet to be able to jump in and really do something that makes a difference.
A lot of folks are on statin medications to drive cholesterol down. We're not going to get into the weeds as to whether that's good, bad, or otherwise. It's irrelevant. Sometimes people need them, and there are some select cases where I would argue other treatments might be better. In some cases, people aren't taking them, and they damn well should. A lot of my patients all scold and say, "Are you crazy? You need to be on." But then choosing the right kind, right? So simple example here. These are both going to drive cholesterol down, but there's a caution on this due to this is a Jane Doe example, this individual's ability to process the wrong kind. And you kind of mentioned something similar, but rhabdomyolysis is nothing, to fool around with. You feel terrible. Right. Your muscles are achy, you can't function, and you're having problems with energy production. It's just a horrible state to live in. Some folks with this sort of cautionary indication, not just a full-blown, my genes can't process this, but just intermediate, may have this and just live in subclinical, poor quality of life, right? I mean, this is kind of it. This is not just you might die from the wrong drug. This is quality of life and health span.
Well, and like rosuvastatin isn't even on that one. So what about all the people on rosuvastatin that are like, well, does that mean I shouldn't do anything? Does that mean they didn't test it? Does that mean, well, so what I can tell you is as our genetics continue to expand, as the drug categories continue to expand, then we look at those and see if they appropriately fit in or not. But again, for this Jane Doe or example patient, we can say, based on your DNA, which is not everything, it's a blueprint, but most likely you would do the best with X and you'd do second best with Y.
Yep. A lot of folks taking proton pump inhibitors as well for GERD, gastroesophageal reflux disorder. These are common to show up with cautionary, and often, boy, you better change this out. Otherwise, I mean, I'm familiar with at least 3 class action lawsuits in the U.S. right now, active and ongoing, as it relates to some of these things being used well beyond their indication for use for the term of use anyway, causing osteoporosis or contributing.
I've got people that I tell them you should be on this for 6 weeks, and they've been on 20 years.
Yeah,
and you're right.
What I'm referring to.
They have so many chronic health conditions that have been developed because they've been on it. I said, do you know that all of the studies, when this was originally done, only shows 6 weeks of usage, and then you've got to find the underlying cause.
Right.
But they're like, but I feel so much better. And it's like, well, okay, but you're taking away your acid-base barrier. You're taking away your ability to absorb minerals. You're taking away to digest your food. Now you have rotting food in your gut. So do we want to do this short term? Sure. Especially if you're having an acute problem. But long term, it is not about shutting your body down. It's about let's find the best alternative to support the rebuilding of your body.
Right. And then, of course, we're familiar. Well, if you're a patient taking an antifungal, you're familiar with often a dermatologist would prescribe this for fungal infections, but they're checking your CBC and liver enzymes because they're chronic, contributors, regular contributors to liver dysfunction because of the weight of processing the liver, the work the liver has to do to process these drugs. So these are often common contributing factors. Antidepressants, we alluded to that earlier on. Like if you're going to have an issue, this is one of the categories of medications that are very common to have an issue with because of these, as I tried to refer to, these cytochrome P450 enzymes, which are so liver dependent enzymes to get rid of this stuff once it's done its job. So there are often some insights if you're needing to take an antidepressant. You mentioned you mentioned some beta blockers, I think you talked about blood thinners, muscle relaxants, again, opioids. There are a bunch of these classes of pain medications if you have to take them. Even ADHD, attention deficit hyperactivity disorder. Yourself or your child, for that matter, might be indicated for this, but which ones are going to work the best for you? This is the question. Which ones are cautionary? Which ones should you try without the hit and miss approach, right?
Well, I love I think it's Denise, not Dennis, but I'm only seen part of it. I think it's Denise. I've never had high cholesterol, rather a normal CTA and heart cath in 209. I've been off of the Crestor. They're off of her drugs since 19. Just had another heart cath in February, and all the cardiovascular disease reversed, both the hard and soft plaque. Thank you, God. Through DNA testing, I was able to discover what I had. And, Denise, those are the kind of things that we love to hear, that you really participated in your own health. You participated in your own healthcare. I'm sure you had several of your physicians that were going, well, I'm not sure what's going on, or it was a miracle, or, well, I'll never see that again. But when you know your blueprint, when you know your pathway, when you get a PGX to give you the best likelihood, rather than going through the experience that you had, and give, the different side effects or the problems or all the muscle tears. I mean, how fabulous to be able to avoid that, and then be able to see the lifestyle changes, perhaps the supplement changes, perhaps they had you on some other chelation type things, but you move through it to get from point A to point B, and you had a resolution. And now you're like, now I know what to do. I know my ideal workout. I know my ideal food. I know my ideal rest, because I know my blueprint. And that's the biggest thing that I think you can take away, is that we are all unique. And yet, I love, she says, my cardiologist said he knew that cardiovascular disease could reverse. He had just never seen it. He'd never seen it because somebody didn't know their blueprint and didn't take it to the next level. So theoretically, he'd heard, and that's why there's a lot of these preventative cardiologists that are coming up now going, we can't just cut people when they're all the way to the end. There's got to be a way to stop this from getting there. Denise, that is just absolutely awesome. Congratulations again for being, that light where he says, well, I don't know exactly what she did, but, well done. Now that would put him out of practice. So he probably doesn't want to share the DNA company, but you could stand outside and hand out flyers about PGX. We love watching people have actionable results. And I think that's another thing I love about our company, is a lot of the DNA companies give you fun to know facts, but our facts are really about the genes that we report on. We report that have actionable results. I don't absorb vitamin D. How can I get vitamin D? I don't process vitamin A. I can't use a synthetic beta carotene because I can't convert it. I've got to use an animal-based vitamin A to get it done. I mean, I really love that all of our stuff is actionable. I don't process dairy. I should not be eating dairy. If I eat dairy, I should be taking enzymes to eat my dairy. And if you overlap that with the pharmaceutical, and the pharmacogenomics or a PGX, I mean, oh my gosh, maybe I don't want to take drugs, but should I need them, I want to be able to take the right ones so that I can heal or manage or maintenance without all those pesky direct effects that make you go, oh, what's worse, feeling the awful that I felt to need this, or feeling the awful that I am on it? And I can tell you, more people than not feel helpless and say, I don't really have a choice. This is what they say I need to get over it. But again, I'm not trying to pick on statins, but I can tell people when they start their statins, I said, look, this is going to lower your cholesterol. Cholesterol is needed for three things. It's needed for your brain to think, it's needed for your cells to repair, and it's needed for your sex hormones. So if you start feeling like you can't think and you can't remember where your keys went, you stop wanting to be intimate with your special partner. And if your get up and go is got up and gone, you're on the wrong one or the wrong dose. Come back and see me and let you know. And I will have people say, is that's what's going on? Because my doctor's so thrilled. My numbers look great, but I feel like, you know? So then I say, let's get you changed. Let's lower your dose. Why don't you suggest, to them that you try another category within here? And then they come back and they go, I can think again. My wife was thinking I didn't love her anymore because I didn't want to be intimate. Now we got our groove back. How fabulous is it to be able to say, it's not your fault. It's those direct effects because you're on the wrong part of that for your genetics,
Yeah, and to be able to reduce drug, reactions by 50%, some of the research shows, cut down the trial and error times, get to what your body, the drug that's best suited for you fastest, especially in mental health. Trial and error issues lead to direct deaths because of timing. Especially in severe depression. So, and then of course, improving patient adherence by ensuring the fact that a drug is effective. Because I want to drive this home, that this idea that 90 or so % of people have direct genetic variations that impact drug metabolism, poor metabolizers, as we're kind of alluding to in the poll questions, or let's call them detox pathway variations that aren't so ideal, can experience toxicity, direct effects, even at standard doses. While ultra rapid metabolizers often don't see a benefit. And this directly explains why this sort of trial and error prescribing often fails. And again, especially with psychiatric medications. But there's also this class, and I'd love you to speak a little bit to this, Dr. Steph, this concept of drugs that are genetically contraindicated directly, meaning some of the most prescribed drugs in America are for cholesterol management. We just talked about that, statin medications, antidepressants, antihypertensives. But you'll have a statin linked to a gene we call SLCO1B1 mutation, which is going to almost guarantee you an increase in muscle pain risk. You have certain chemotherapy drugs can be very toxic to individuals with the DPYD genes that are poor. And then, codeine and other pain medications can be outright dangerous for certain CYP or cytochrome P450 variation genes, not just poor, but those that are ultra rapid metabolizers, right? I mean, these are genetically contraindicated, are they not?
They are. They absolutely are. And, you are, as the clinician who goes in, one of the main things that I do is I see people who talk about their side effects or talk about what they want to achieve. And then I find them working down the pathways. You, as a co-founder of the DNA company, have so much more of those mechanisms than I do. So when you're asking me, I'm like panicking, going, I can look them up. I know in my little autoimmune world and in my little BHRT world, I can go through a lot of them, but all the different classifications to pick each gene, I'd be lying to tell you I got it all memorized.
Well, no, but hats off to you. You are a gal and clinician when it comes. I mean, you have such a breadth of knowledge. It's crazy. I just being around it and seeing it for as long as I suppose I have. And by the way, it takes a village, right? I mean, we all have our various areas of expertise. Mine happens to be in nutraceutics. I put all these things together, and in my mind, the first things that come to mind are ingredients. How do I optimize a particular drug function given pharmacogenetics and even pathway genomics? How do I use an ingredient to make this drug work better in this individual, or a supplement that I never like the word switch out. That's not what I do in clinical practice. I will not switch out or recommend people switch. It's always on them for what their doctor or prescribing doctor says. I'm an ancillary healthcare provider with certain provisions, but I'm always looking for the ingredient. Like, for example, I'll give you an example. Poor statin metabolizers, right? We were just talking about those folks. If you're really doing the deep dive on a lipid panel, functional, meaning if I know what your cholesterol levels are, and that's not the whole story, but now I know your inflammation levels, and I know your genetic predispositions, and I know your particle size, and I know your oxidized LDL, and I know the predisposition that you might have that deposits, because the story really isn't about cholesterol, it's about how there's a warrant of that cholesterol deposition, which is called inflammation. If I know all these different things, and I'm just like, you know what? We're not at a place yet where we know that there's anything better for you than a statin. I highly recommend you take a statin. Well, then along with the statin, I'm probably also going to say you should be on ubiquinol. And we
I was
both
going
know
to say
that.
CoQ10. Yeah.
CoQ10, but also PQQ.
Mm-hmm.
And also probably some things to help upregulate mitochondria, because one thing that we know statins do is rob, and that's way oversimplified, but rob our ability to make the currency of energy, ATP, and depending on your genetic variation. So there's always the ingredient that can offset or make a drug work better. Or not always, often there is that ingredient. And that's I guess in a summary, sort of one of my areas of expertise.
But I'm going to do a shameless plug, because Bryce was so instrumental in doing our black label. So, when I was talking about the supplement that maybe somebody took off of a shelf from a big box drugstore, I can tell you that most of that stuff is crap. One, because I worked for pharmaceutical companies for a number of years, and two, I've worked for some big box, and I can look at them, and then I can actually take whether it's a B12 or something else and go, that isn't working, and that is all magnesium stearate, that is all lactose. But when you look at the quality of supplements that are for healthcare providers only, the reason they're for healthcare providers only is because they're therapeutic grade. When you take somebody like Bryce who goes, well, yeah, you need a statin. Okay, cool. Your doc wants you on a statin, but you're going to be depleting your ubiquinone or your CoQ10. So let's get you an activated CoQ10. And then you need the PQQ, and then a little D-ribose so we can get that ATP to go in. And he puts together these great little formulas that makes your statin not only work, but then makes the rest of the body be able to accept it. So it's kind of like having a dry cake versus having all the frosting and all the sprinkles so that everything just tastes better. Like, if you don't have good supplements, then you ought to look at the DNA company black label, because they are far and superior to most of what's out there. And they are put together, with the genetics in mind. Gosh, what if we have somebody that has low comp? They couldn't have too much of that. What if we have somebody who has high comp? Boy, we want to be careful of that. And so they've all been crafted, looking at our genetics, looking at our population, looking at what are the cleanest, most impactful things that we can do. I've got people who have said, I haven't been able to sleep. I haven't been able to detoxify. I've got horrible allergies. They get on our detox. They get on our sleep optimizer. And all of a sudden they're like, life is better. Like, I had no idea how much life I had lost, that I was walking around like a zombie because my body was not taking in things that helped me process. And kudos to your brilliance. I mean, I've done some formulating. I love the idea. It's kind of like a good recipe. And I love doing black labels for my private clients. But to put together the quality that you've put together and the sourcing, and, it's just like they blow almost anything else out of the water. And there's some great supplement companies out there. But Bryce, what you have put is just like, so, hats off to you.
We're incredibly picky. First of all, I have to say none of that happens without the dedication and hard work of an entire team.
Sure.
And I got to extend kudos to Dr. Krista Kosterman, our chief of science, because none of this happens without her. But being picky and making sure we go to the source and understand safety and transparency of ingredients and traceability and efficacy. Science has got to be there. And unfortunately, a lot of the supplement world is still very much buyer beware, and or mostly often in pixie dusting, which is just too little of
Yeah.
maybe it's a great ingredient, too little of an ingredient, maybe not the right source. Anyway, yeah, this is part of the story. Sometimes prescription drugs are necessary. Make sure that they are genetically paired. The best is if you really do need them, and then when they are, let's add a little bit of more of what your body needs. No miracle medicine here, no miracle to any of this. Getting your body to work better on its own
It's
with
all
a
plain
genetic informed
biochemistry.
pathway. Yeah,
It's all plain biochemistry. Your body is not a gynecological box, a urology box, a neurology box, a cardiology box, a dermatology box. It's not that. It's like a skeleton watch that goes like this, and they all work together, and each one is impacting the other one, and they're all in this one beautiful box called you. So we've got to be real careful that that box is full enough to heal, but not so full that it spills over, and then you have that toxicity. And
right.
again, that's why doing your genetic testing, doing a PGX testing, using quality ingredients, working with a coach that will show your best exercise is, your best sleep is, your best detox is based on your genetics. And then most of our practitioners and clinicians like myself will look at your blood work as well, look at your Dutch test as well, look at your saliva tests. I mean, you layer, it's like a Venn diagram. You layer each one of those over between side effects and results and desired effect, and then look at your genetics and move you to the place where you have a demonstrable result, the way Denise did, you know. And it's so rewarding. I was working with a client yesterday who I've had 4 sessions with her. This was the end of her time. And she's like, I'm sleeping. I've lost my extra weight. I no longer have the skin irritation. My brain is working again. And I mean, we've done the 4 sessions over a year. And so she took this year in her late 60s to rejuvenate her health. And now her skin was vibrant. Her eyes were bright. You know, it was just so neat to see working through all her issues. She said, I want to invest in myself because I'm, you know, about ready to do full retirement. She'd done partial retirement, but she said, what fun is being retired if you just want to sit around and go, meh. Now she has her life back. You know, like you were saying, investing in your health, or I guess it was Tracy that was saying, you know, if you're over 40, you're on the backward end. Well, you know, most people go up and then they do this. Not me, man. I'm going up. I'm going to go here and then drop that last day, you know, but until that last day, you know, you cannot drag me down.
For me,
so we just lost Bryce. I heard him echo, and then drop. So Tracy, I wanted to say there was an interesting comment that Nina put up. I think you should see if you can text Nina privately. She had a neat kidney test or a neat kidney thing that she's developed that I think is be worth looking into. It sounded like it was kind of cool. I didn't have
all right. I'll take care of it, Doc.
Yeah, perfect. It's no problem that you guys have to go. You will get a replay. I think we should jump in since Bryce just dropped off. I'm sure he'll be back in a minute. Let's see if we can answer some of these questions. We've got a few on here. Will you discuss matching cancer drugs? So if you saw, Janice, on the PGX, we do have anti-neoplastics on there. So we definitely have some of those. And depending on what kind of cancer, you may have heard of some of our other webinars that we've had. 70% of cancers that are tested for are actually not routinely tested for, but we do have an amazing test called the liquid biopsy that does test for them. It can show you per propensity. It can show you the likelihood. I will tell you that when we were looking at some of our new tests, one of them is a breast cancer test. I volunteered to be the guinea pig. And I just knew that mine was going to come back absolutely normal. Well, it did not. It came absolutely back not good. And I was like, what the heck is going on? I knew I'd had some inflammation from the last year. I knew with my BHRT, I was having some breast tenderness, but what it caused me to do is to do a deep dive and go, yeah, I am really not interested in breast cancer. And so having that DNA 360, say I had a clinical result, and then dive into, getting my mammogram, getting a automated, what they call it, an A-bus scan, because I have very dense breasts, changing some of my BHRT, changing my diet, even though I've had a really clean diet compared to 99% of people, it wasn't clean enough for me. I've been able to drop my inflammation in a matter of about 6 months, more than 20%. So everything has just gone like cleaned up, all those little things. When you start to get in your 60s or 70s or beyond, a lot of us have these, well, it's just the way I am. Well, it's just the way that I am. And as much as I'm so proactive with health, it was through one of our tests that I said, I got a early heads up. Hey, I'm on a path toward, and I choose not to. And now I can see all of those recede, and I'll be doing another one in 2025 just to make sure I continue, because I'm really looking forward to get not clinically significant. And so it's really powerful when you can look at whether you have your PGX, or you look at a liquid biopsy, or you look at a DNA 360 to say, hey, where am I on that path? What do I need to have a heads up on? What could I do differently to keep myself away? I am major in prevention. So I hope that helps a little bit, Janice. Welcome back, Bryce.
Yeah, I don't know. Sorry about that tech glitch.
Yeah, no, it's all good. No, just makes you know how much we appreciate you. Marianne, how are steroid inhalers like Trilogy detox? So steroids, it's not about the steroid inhaler. Steroids turn into cortisol. Cortisol can make you a night owl. Cortisol also suppresses the inflammatory reaction, and that's where we get all this fungus. So you get thrush. This is why when you have a steroid inhaler, we say you must rinse your mouth. You must gargle or brush your teeth so that you don't have that buildup. That steroid goes down into the lung and shrinks the tissues. Why are you having chronic lung tissue inflammation? It could be something in your diet. It could be something in your environment. It could be something, so the pathway for detoxing is the way they detoxify all the steroids through our system. And most of that goes through the liver.
3A4, right? I mean,
Yeah.
primarily.
Right. So how about you take this next one, Mary Kern? How does one find an MD with functional medicine training who understands DNA reports? And is a poor detox system a major factor in neurotoxicity or taking the right pharmaceutical?
Yeah. Well, the first part of that question is an easy one to answer. We have a number of excellent FCP trained functional genetic practitioners at the DNA company. So we're our first stop for sure. And then there's the IFM, the Institute of Functional Medicine, where a lot of those listed come to us for additional training in functional pathway genomics. So get in touch with our clinical team. We'll put something up. I'm sorry, my glitch out didn't allow me to see any of the questions. You're gonna have to read them out
Sure.
for me here. But at the second part of her question, I think was related to if fungal infections ensued and caused neurotoxicity. What was the part?
It says, is a poor detox system a major factor in neurotoxicity results from taking pharmaceuticals?
Right. So when obviously you've got compromised or suboptimal detoxification pathways, where again, most, if not by and large, the majority of pharmacologics work. And again, early days, they become their active, they split, and the metabolite, and the active has to do its job. And then, both of these things have to be turned into water soluble molecules that have the chance to exit out of your kidneys, so through your liver into your poop. That's why we say pee it out, poo it out, breathe it out, and sweat it out. Those are our main pathways. That's why saunaing is so great. But when they accumulate over time, the body does such a desperate job to get toxins out of the circulation, blood, serum circulation, and out of the body. And if it can't do that, it'll store it into fat. And unfortunately, a large majority of where your fat sits, it also is where your central nervous system sits. And there's a cross translation there. So unfortunately, a lot of toxins, it seems counterintuitive, but the way the body is designed, it's unfortunate but true that a lot of toxins, including these, are allowed into the brain, central nervous system, and peripheral tissue. So yes, one equals the other, no question. I wouldn't say always directly, but almost always indirectly. So, but here's the good news. There are ways to recover from that. There are ways to understand from a pharmacogenomic perspective which drugs, if you need to take them moving forward, are far less toxic for you. And this is why we talk about detoxification protocols all the time, because even if you've got toxins stored up, there are ways in which you can excavate them, I suppose, out of your system, and reverse a lot of the symptomatology that has ensued from toxin buildup into neurotoxic symptoms. So that's how I would summarize that.
Yeah. And the only thing that I would add to that is we have over 30,000 practitioner partners that have taken our DNA course or worked with DNAU or follow us regularly. And I know that if you reached out to concierge at the DNA company, if you need a referral for your area of someone who's familiar with or has trained in our DNA university, that they'd be happy to give you a local referral for your area. So we have more and more people that are training, are wanting to add DNA, are wanting to add a DNA that really creates results. And so they're partnering with us through DNAU. And it's just so exciting to see how DNAU is just growing. And that's another way to get a great referral. Carol asked, she worked with a company similar a few years ago, and they generate reports that are similar to what we're referring to today. And how does ours different? I don't know the company and I don't know the report, so I don't think we're going to be able to share that one with you. I know when you go on to our website, you can see what our reports on, or if you have a specific question, then you could also send that in to concierge and they could send that up, and management might be able to tell you, or they may pass it over to one of our us clinicians and ask us to look. But at this point, I couldn't give you an honest answer, not knowing what their report does. And our reports are always changing and upgrading. 2 years ago, when I started with the company, we reported on 72 genes. And we are now ready to release, our next one where we're adding 10 more. And I know in 2025, we're looking at adding 20 more. We don't add something to our reports unless it's actionable, definitive, backed by clinical science, and we can demonstrate that you can get a result from it. So again, some of the reports say, hey, can you curl your tongue? Yes, I can. Okay, I can tell you that. I didn't need a report to tell you that, but that's a genetic trait. Okay, that's a fun to do. It's a party trick. But does that create a better health? No, it doesn't. Some people can tell you that they eat cilantro and it tastes soapy to them. That's a genetic variation. I happen to love cilantro. I can eat a ton of cilantro, and some people cannot have any of it. That's a genetic trait. Our traits are the actionable. Can I reduce cardiovascular inflammation? Can I reduce estrogen dominance or estrogen toxicity? Can I feel better because, I'm always needing a quick hit or a quick fix for nothing? No, my pleasure doesn't seem to last. These are all genetic traits. Well, if we can say, hey, you've got plenty of dopamine, you just clear it so quickly. How can we slow down that dopamine? Or how can you reframe so that you're not deficient, but that, you can function within this, and you can turn what you see as your weakness into your superpower. Again, having PGX, it's like, do you need something to support you beyond food, supplementation, lifestyle? Perhaps. And if so, let's give you the best fighting chance so that you can actually feel better and optimize your mental well-being, your physical well-being, and beyond there. So I already have my DNA test done. My son is missing 2 glutathione genes. Oh, that makes it tough. Has methylation issues. He can't process anything that increases serotonin. Now that's also really tough. He previously had symptoms of serotonin syndrome and was given 5-HTP. Now, Bryce was talking about this. If you take 5-HTP, it's going to stimulate serotonin. If you stimulate serotonin, some people get a syndrome called serotonin syndrome, where they are super wired, and can really hurt themselves. So he had symptoms of serotonin syndrome, was given 5-HTP, and will throw up if he ever takes a B6. Okay. Tap water makes him unwell, probably from the chlorine or fluorines that he can't detoxify. Makes sense. To maintain good gut, skin, and respiratory health, he has to only eat organic foods and as close to how God made them to avoid environmental toxins and pesticides. Great, because he doesn't detoxify. He was vaccine injured over 18 years ago, and it still affects his leg and requires constant therapy. He's not been vaccinated since. He's on the autism spectrum because he has struggled to detoxify. He's made leaps and bounds with his detoxification and methylation, thanks to his report. I have bought a PGX test for him, but I haven't done it yet. Would the test be able to tell me if he should or shouldn't be vaccinated in the future? Can I use it as an advocation for his medical safety? So the PGX, and Bryce, I'll have you respond to this as well. The PGX is simply going to say, based on his DNA, here in these various categories, cardiovascular, statins, antidepressants, anticonvulsants, here is the least likely to cause problems. Here is the most likely. It's not going to say anything about what he should and shouldn't do for lifestyle. It's not going to say anything about should not have a procedure or anything. You will get more of that from the DNA 360. So if you're looking at have him on medicine, an ADHD medicine, an anxiety medicine, a cardiovascular medicine, if he has to be on medicine to control some of his situation, the PGX will give you, based on his DNA and his inability to detoxify, the most likely, the most effective for him. So it may help you in choosing the least offensive option. But no, will it tell him to vaccinate or not vaccinate? It will not. Can you use it for medical advocacy and safety? You can, provided you're looking at the pharmaceutical aspect of it. Yeah. Bryce?
Yeah. No, I would just summarize what you said. I mean, it's going to clarify medication risks, and that would be helping to avoid not just serotonin syndrome, which is now through trial and error, other adverse drug reactions, should there be one that he needs to take in the future. Direct effects, not side effects.
Mm-hmm.
But having somebody look, our reports don't tell you what supplements you should take, meaning the PGX. Our DNA 360 can inform largely. The PGX doesn't say what supplements are good or bad, or what nutrients are processed or unprocessed. But a practitioner that's well informed within the realm of functional genomics, pathway genomics, and pharmacogenomics can infer to avoid triggers. For example, even B6. Find alternative support if he's throwing up from B6. That might have to do with the methylation pathway.
That's what I would guess too.
Yeah, and 360 when it comes to optimizing detoxification as well. So supporting energy recovery, that mitochondria inferences, neurotransmitter inferences, that's all 360, like you said. But clarifying medication risks, and by the way, when it comes to informing vaccination injury, no. But there are genes, there are what we call cytokine profiling, genes that indirectly and directly inform how your cytokines, pro-inflammatory markers that inform the immune system, work. So these are indirect off-label. That's how I'll describe indirect off-label. Information that we can derive, and that can give us a bigger picture. So what I had summarized in saying is a PGX can really help further inform. not, yeah, it's going to give information around what you should or shouldn't take from a pharmacologic perspective. Obviously, that's its point. But you can cross over and inform some other subtleties between it and the DNA 360 that can give your son a much more robust, comprehensive plan moving forward.
Absolutely. Bryce, does a person need to have more than one DNA test review, or do they need to have a DNA test annually?
So DNA never changes. The science around genetic insights change pretty much on the weekly, and even faster. It's following this real astute curve. But so I would say if you wanted a skim glossary top line, just the actual pain points of your report, and wanted the top most important things that you need to action on, I'd say that's probably 2 or 3 touch points, 2 or 3 appointments, each of which are pretty deep dive. If you really want to understand your instruction manual, that's one of our programs. And that takes many, and I mean, listen, this is just the science. You and I both know our reports intimately well, to go through them with meaning, deep meaning, and really help to evolve and extrapolate dietary, lifestyle, supplemental, pharmacogenomics, drug interaction. This, as anyone can appreciate, is many, many hours, and you can't do it all at once. Even if somebody had 6 hours to spare, you would never sit for 6 hours, but maybe 10 45-minute appointments. So it's multiple touch points. So where DNA doesn't change, and that's a great question. It's actually brilliantly asked, the way it's structured. So first of all, the deep dive is going to take many touch points, or should, depending on how deep you want to go. And we should all probably go pretty deep if we can afford to, both for time and of course, as our CEO just said, about an hour ago, your health is an investment, never an expense. And probably what not probably, you've seen it time and time again, the energy, the attention, the focus, the alertness, the better sleep, just better performance, better showing up to work, all this improves. So the investment you make in clinical consultation, which is what we do so well, is going to pay off in droves. So ROI is huge from both a health and financial perspective in this instance. But this person asks the right question: should it be reviewed annually? Because people are people, and we forget, and we lose track, or so yes, as a reminder, and also to review and be updated on the science, because as clinicians, if we're doing what we should be doing, we're updating ourselves on the science. So you may not have, with the same report, may not have heard what we have to say with an update in science a year from now.
Yeah.
So
you only have to do your DNA once, because the DNA doesn't change, but to review it frequently, either in the beginning because you have something or because something comes up, is a great idea. You can do it being on our podcast, being on our webinars, working with a clinician. We have packages that give a reduced rate. And a lot of times you can also do an episodic. So if you get a PGX, you get a session with a clinician to review it, and you get to ask questions. Well, they want to put me on statins. What should I do? They want to put me on, an antidepressant. What should I do? And then, so the clinician will help you walk through that as to, this is your DNA. This is what your report says. This is what you want to present to your provider so that you can optimize your health. So you only need the DNA once. Yes, when we have our DNA reports update, you will get those updates for free. So when we get those 10 new, SNPs and stuff that are going to be coming on, your profile will be updated. And that's a great time to review it to see what that new information is.
Absolutely.
I've got
I would just add really
Yeah.
quickly to that too, as well,
Yeah.
because our reports, what we divulge and what we show is tip of the iceberg. A clinician's going to unpack and open up so many of these genes and explain them separately and together and through all the pathways that we're so good at describing. I'll give an example. Within cardiovascular reporting, we talk about the ApoE gene. Apolipoprotein E gene plays a really important, very significant role in lipid metabolism. So very closely associated with how your body brings cholesterol around, cardiovascular health, but also obviously brain function, variations, profound clinical implications for cognitive decline and Alzheimer's. So here's the thing. a single gene, we never look at it, on its own, but in context of pathways. So if your ApoE gene is optimal, 3 or a 2-3, we may not talk a lot about it in a report because it's not what's glaring as problematic. But even a 2-3 optimal ApoE in conjunction with something else like BDNF, in conjunction with other aspects of how your body carries vitamin D, now we have this whole picture. It's not a glaring red alert, do something about it, but it can inform what foods you should eat, or what lifestyles you might want to consider as priority. And so you don't get to that until you kind of graduate into a pretty extensive deep dive into your genetic reporting. So I just wanted to mention that.
Yeah, that's absolutely great. Two more things. PGX for cancer chemo treatment looks great. But what additional help does your other cancer test, meaning the lipid biopsy or liquid biopsy, once you've been already diagnosed, say liver cancer stage 3, and you have no energy? So the thing that I would say about the liquid biopsy is, okay, you already know you have cancer, but the risk, especially at a stage 3, is where is it metastasizing? In a liquid biopsy, you're going to see all the DNA from all the organs. Is there something else brewing kidneys? Is there something brewing brain? Is there something brewing? It's going to allow you to see, or your provider to see, hey, these are the areas that look like they could be brewing. And so while they're focusing only on the liver, kind of like I talked about before, you don't just have a liver box. You've got this whole box. Where is this cancer seeking out to do? So that may be a way to manage it. Or if they can get you into remission, or if they can stabilize you, then it's a way to look, hey, is something brewing in the future? Is something coming back? So Bryce, would you add anything differently about liquid biopsy or using any of our other tests for a stage 3 liver cancer patient?
Yeah, insights into tailoring, detox support, nutritional support, inflammation, immune function, all this can be extrapolated, restoring some energy with a focus on mitochondrial and metabolic health insights. I think, I think you just said it, but also monitoring for, it's not just liver box, monitoring for residual disease or recurrent risk, right? And then, of course, there's all kinds of, post-treatment gut, liver, gut, brain, hormonal recovery, like all these different things that are upset in the process, right? Not just genetic predispositions to some of these being compromised, or even pharmacogenomic, scenarios, but what's the fallout on all these other systems? So would PGX help in this context? Yeah, I mean, it could still provide insights into optimizing medications for symptom management, nausea, pain, mood, and supporting any of these sort of what we call comorbid or concomitant conditions. So whether they're the fallout of gastroenterological or cardiovascular. So I think there's huge value.
Yeah. So I do see that Janice is interested in Liquid B. I don't know if we can give her Allie's number or Allie's email or Tracy's email or concierge, somebody, so that if you can reach Janice so that she can figure out how she can get Liquid B. I have two more things. One, would love to see the DNA company come out with a way to help parents navigate the vaccine schedule based on an infant's DNA profile. Could there be any possibility of that in the future? Now I'm going to spring this on Tracy. My favorite VAX resource for parents is called vaxcalc.org, VAXCALC.org. And the person who runs it, his name is Chris Downey. And you can set up information to look at what's in the vaccines, the different vaccines, and you can do a calculated risk. He's got a whole computer program. Trace, I think it would be awesome. I can reach out to Chris. I would love for us in his VaxCalc for his clients to be able to do DNA tests. And I know he would work that into his algorithm, which would give so many parents a huge relief to go, hey, my kid doesn't detoxify this. I don't want this. And then they can bring that data to their pediatrician or to their provider and go, hell no, I won't go, or sure, I'm okay with that one. Would you be open to something like that?
Yeah, of course they would, right? So,
Mhm.
here's the thing. If you choose to vaccinate yourself, your children, that's none of my business.
Mhm.
If you choose not to vaccinate yourself or your children, that too is none of my business.
Mhm.
I I am not going to put the company or any of the clinicians in a position where their licenses could be in jeopardy. But what I will say is we are open to all things as long as it's science based and proven.
Yeah.
And first, do no harm. And if
Right.
we follow those rules, I'm 1,000% committed to contribution to the greater good. However we do that, Dr. Nielsen, I'm in. So whatever
Yeah.
you need from me.
So if we've got an infant's DNA profile and then they use the calculator that shows the constituents and the ones that could mess up with some of those pathways, or those kids like myself as a kid who
Right.
none of the drugs worked, and we could show, look, she does not detoxify. This is going to put her at risk. I mean, what a great resource for parents. So I'll
Right.
reach out
Well,
to Chris this week and see if we can
yeah.
do something with
I
that.
mean, look at my oldest daughter, Steph. She was
Right.
diagnosed with leukemia at 2.
Yeah.
So she didn't get vaccinated like the other kids, right?
Mhm.
So, again, it comes down to clinical efficacy and really what's best for those children and for that family. It's a family decision.
Absolutely. Debbie, what a
Yeah.
great idea. Thanks for prompting us to stretch even further and serve even more. We really appreciate that. Um, I think that the greatest gift that we have is to give you access, and to give you access to what we have, know, love. And so our company is being very gracious, offering you all holiday cheer with, you get 15% off when you order 2 or more tests. So you get to mix and match. We're not going to offer you, hey, this is right for you, and this is right for you, and this is your special price. It's, go look at our, smorgasbord, look at our menu and see, after you learn tonight, is PGX right? Is liquid biopsy right? Is breast 360 right? Is the basic DNA 360? What is it that would serve you and your family? What is it that would serve, you and a loved one? And we'd love to give you 15% off during this holiday season. And it's good until December 31st. I'm also going to encourage you to really go take a look at our Black Label, products, because again, Bryce did such a beautiful job combining the highest quality, sourcing the highest potency, and putting them together in such effective. People who are on Black Labels now said, I didn't, I thought, supplements were just made me have expensive urine. Now I realize what I was missing. I didn't know what I didn't know. So, we are grateful that you're here. We get excited to work with you. We get thrilled to get to share the little passions that we have around this ever evolving genomic world, and to work with such quality people like Bryce, like Krista, like Tracy, like, so many, we have so many new clinicians that you will be meeting over the next year. It's just like, it's humbling, guys. It's humbling that you'll spend an hour or 2 hours of your night hanging out with us, just so you can learn more. We love that you're so active and involved in your own health, and we just want to contribute to you and your success as much as possible.
Yeah, it's wonderful that people are catching on to the notion that your health is an investment, never an expense. And by that, I don't just mean financial, it's time. Like you said, we appreciate people spending the time and investing that time into their health. And obviously, the whole point this evening is that your health journey doesn't have to rely on guesswork, that your DNA holds the key to making, I would say, smarter, safer for sure, more effective choices. There's no question for medications and overall well-being. So please, if you're ready to take the next step and you've done your DNA 360 or you haven't, this is a pretty exciting opportunity. 15% off when you order any 2 or more of those tests. And Dr. Steph, thanks so much for everything that you do.
Thank you.
And
I'm putting in vaxcalc.org. There's some people were
Yep.
asking. So
There
if
you
anybody
go.
needs that website to check it out for a kiddo or a grandkiddo, or, anyway,
Yeah.
we are blessed to serve you. We are blessed that you love what we do. We love what we do, and we love being here. And we just thank you for your time. We wish you the greatest holiday season with your family. And there will be a replay of this. So grab somebody, sit down, talk about it again, and make your decision on giving yourself the gift of health in 2025, because we'll be here for you. We look forward to it.
Stay well.
Take care.
everybody.
God bless. Good night.
Thanks, everybody. Thank you, everybody working on the tech side.